So we'll go ahead as the people filter back in, okay? What I've tried to do is I have some overlap with the talks, but again, I've tried to pick areas where we haven't spoken about this or I haven't spoken about it, so you'll get a flavor for some other diseases as well. So this is the first question here. Which initial patient presentation, patient coming to you the first time, which presentation is least likely to be associated with minimal change disease? Is it the 65-year-old white male with AKI and 4+ proteinuria? 32-year-old white female with 2.1 grams of proteinuria? 45-year-old black male with 9 grams of proteinuria? 28-year-old white male with hypertension, hematuria, and 4+ proteinuria? Which is least likely to be an initial presentation of minimal change disease? Okay, now I hit on this, and there we go. We're starting to get answers coming in. Remember, we need 50 to move ahead, so you may have to vote 2 or 3 times. Oh, we're stalled. Okay, even those guys who have no idea, just vote. We're there, okay. And the answer is okay. So we'll see how we do as we go through these. So the answer, and you can see you've got a fair splay here, that we haven't talked about minimal change disease. So it turns out that the person who is least likely to have minimal change disease is the person with 2.1 grams of proteinuria. It is very unusual for somebody to present with low levels of proteinuria as an initial presentation of minimal change disease. So here's our minimal change disease, and remember the old name was nil disease. Nil disease stood for nothing in light microscopy. Here's our fused foot processes over here on our basement membrane, etc. So this is taken, here are 5 pearls you can get from one study. We looked at 95 adults with minimal change disease. This is back when Merrill was a fellow at Columbia. She's been at NIH ever since. But in any case, look at the mean GFR, 72 cc's a minute in these 95 adults with minimal change. The mean creatinine was 1.4. Now, whether this is due to concurrent ACE inhibition in ARB, whether this is a little volume depletion, but it's not unusual to see somebody with a slightly elevated creatinine. Look at the average proteinuria per day, almost 10 grams of proteinuria. There was nobody who had 2.1 grams of proteinuria. If you presented with 2.1 grams of proteinuria, it's another disease. You're making a mistake, and again, we can talk about what diseases later. AKI at presentation, 17%, eventually 24% had an episode of AKI, which either reversed or came all the way down or went up after being normal. And there was no difference in response to daily or every other day steroids. We'll talk about that. 40% relapsed by 6 months. If you know those 5 things, you know an awful lot about minimal change disease in adults. Okay, question 2. In general, adult patients with minimal change disease respond to steroids similar to children and can be considered steroid resistant if they do not have a reduction in proteinuria by 2 months of therapy. Answer 1 is true, answer 2 is false. Okay, 1 is true, 2 is false. Oh, we're getting all those so fast, this is good. Okay, so the majority of you are correct. This is false. Okay, we go out of this. I go out of that. Okay. No. Okay, so this shows you the series that I just said, the 95 adults from Columbia. And you can see that if you go out here at something like 24 weeks, the curve starts, if you're here at 2 months, let's say, okay, 8 weeks, more and more patients are still going into remission. You are not steroid resistant until you've got out almost to 4 months. When you get out to 4 months, the curve gets flat. This is, Marina Vivarelli has put this in a different way. She looked at 2 studies, large studies from children and 2 from adults, one being ours. Look at how the children were. Everybody who was going to respond responded 4 or 6 weeks. In adults, again, it's a slower response rate. So it doesn't mean you have to leave the same high dose up for the whole time. It means taper the dose over time, but they're not steroid resistant until they've had 4 months worth of therapy. Daily, every other day, doesn't matter, but some therapy. Question 3. A 38-year-old white female has the nephrotic syndrome due to biopsy-proven minimal change disease. She has responded to a course of prednisone with a complete remission, but has relapsed 3 times whenever she discontinues the prednisone. Which therapy will give us the highest rate of remission for her treatment at this time? She's had 3 relapses. What therapy should you use at this time? Cyclosporin, cyclophosphamide, tacrolimus, mycophenolate, all of the above are equivalent. Okay. I think we're getting a little slow here. Some of you like the true-false ones, 50-50. And there we go. Okay. Okay. Oh, we got a big splay here. Look at this. We've got all kinds of answers in here. I mean, this is, do we have 100%? Yeah, we do have 100%. Okay, but it turns out at least the majority are correct in terms of this. They're all equivalent. When you look at this, this is somebody who has steroid responsive. They're a frequent relapser, or they can't be tapered down because they're steroid dependent. If you look at that, let's get this off here. Good. This is taken from that same paper. It's in a tabular form there, but this is graphic. But if you look at complete and partial remissions, that cyclophosphamide, cyclosporin, TAC, MMF, they all were the same. Some had more complete, some had more partial at the time. There were only 20 patients in an arm. When you have somebody who is steroid dependent and you're going to choose a second agent, if you have somebody who is a frequent relapser that are relapsing very quickly, think of the side effects. If they're a young person and they don't want to take cyclophosphamide because they're worried about fertility or hair loss, don't use it. If there's somebody whose creatinine is elevated and you're worried about calcineurin inhibitors, be careful with cyclosporin or TAC. If it's a diabetic, you may want to use cyclosporin rather than TAC. If they've had GI problems, you don't want to use MMF. Think about the potential side effects rather than the drug's efficacy because they're all about the same. Question 4. Which clinical and laboratory features suggest that an obese nephrotic patient is more likely to have a secondary hyperfiltration etiology rather than primary focal sclerosis? So what suggests a secondary one? Okay, black race and 9 grams of proteinuria per day, a serum albumin of 3.8 and 3.4 grams of proteinuria per day, perihilar sclerosis and absence of hematuria, a BMI over 40, and a plasma albumin of less than 2, which suggests this is secondary focal sclerosis and not primary. Okay. Wow. I hope you're all right, because that's wild. I mean, you've got in 5 seconds we had it over 60. I couldn't even stop it fast enough. Okay. So, you see, speed doesn't mean everything, but 51% are correct. Secondary focal sclerosis, hyperfiltration, usually has an albumin that is close to normal and lower levels of proteinuria. So the albumin of 3.8 and the whatever it was, I think it was 3.4 grams of proteinuria, this would be typical of hyperfiltration due to a remnant kidney, due to obesity, anything like that. The fact that somebody's African-American 9 grams of proteinuria is classic for idiopathic primary focal sclerosis. Perihilar sclerosis is typical of secondary, but hematuria, you may have it or you may not have it. It's irrelevant. And again, the BMI of 40 and the plasma albumin of less than 2 could very well be a primary. So the answer is less proteinuria, and again, close to normal albumin is much more likely to be a secondary form. Oh, there's our obese guy here. Obese glomeruli. Look at this giant glomerulus. See these, the tubules are the same size. Here's a normal glomerulus. Here's a great big one. Here you can see that focal sclerosing, segmental sclerosing lesion starting right there. Okay, which genetic defect of focal sclerosis is not associated with an autosomal dominant inheritance? Genetics are a huge thing now in terms of boards. There are huge things in terms of journals. They're a huge thing in terms of your patients. So which of these is not an autosomal dominant? There we are. We hit our 50. Okay. So it turns out, one thing about this, the majority is always right. So just look over at your neighbor, see what they're writing down there that on the exam on your boards. So it turns out Potocin is a recessive. That alpha-actinin 4, inverted formin 2, which is pretty common, are both dominants, and the TRPC6 channel are dominants. Now, let's get that out of there. So this slide is taken 3.5 years ago. There were 52 different genes known in humans here. These are all genetic models, but they're all genes that were in humans. You can't possibly know all of them, but the ones I put down are the big ones. Those are the ones that are much more common. You may, even in a big center, you may never see any of these genes in terms of this. So it's worth knowing those few. Again, Potocin is a recessive, autosomal recessive. The others are autosomal dominant. Oops. And here we go. This just says exactly what I said, and you have this in the syllabus. Okay, which disease ultimately proven to be genetic by whole exome sequencing is most commonly mistaken for focal sclerosis on light microscopy? It's a really important clinical point. Nail patella syndrome, thin basement membrane disease, Fabry's disease, diabetic nephropathy. Now, we are doing a ton of genetics. I used to say that nobody could get into my office without giving me a cup of urine. Even the pharmaceutical reps had to give us a cup of urine to dipstick before they came in. Now I say, forget about the cup of urine. Actually, I don't. We want the urine also, but we want blood too. We want to do genetics on everybody. There's always some study they can get into, and it's amazing what you can find out. Okay, so let's see what we think here. Yeah, we're slowing down in the 30s here. This may be one that we don't. Okay, I'm giving you to 20 seconds, or we made it. 20 seconds. No, that's it. Yeah, we just finally did it. Okay. So, this is clearly, an example of, if you don't know the disease, you always guess it. If you don't know the disease, don't guess it. You'll get more right in terms of this. So nail patella syndrome, I've only seen 2 patients in my lifetime in terms of this. Fabry's, I have a couple of patients with that. Thin basement membrane, I have tons of patients, and the answer is 2. That's amazing because remember, that's a form fruste of Alport's. It's a basement membrane defect. So let's look at this. Stop. Okay, good. Okay, so this is taken from the New England Journal in January. But again, the data's been pretty clear for a while. But this is, again, a Columbia study here where we looked at over 3,000 patients. Many of these came from the glomerular center. When you looked at the patients, almost 10% had a genetic disease that they were not aware of or that we were not clearly aware of. And one of the biggest ones here was collagen 4 defects, thin basement membrane or Alport's variants. So very common in terms of this. Let me show you this on one more slide. Here it is. Many were mistaken as focal sclerosis, other glomerular diseases, but again, the biggest group, Alport's thin basement membrane disease. So this is, your patients, if they have a family history and you can't find it, it's worth doing the genetics because you may find out they are a TRPC6 or they may have a Potocin defect, but they're just as likely to have a thin basement membrane, a collagen defect here, and be a heterozygote for that than they are to be anything else. In fact, 56 of the 91 patients with collagen defects did not have clinical diagnoses at the time. Okay, which statement is not true about focal segmental sclerosis? The incidence of focal sclerosis has increased in recent years in the United States, and it is the most common pattern of idiopathic nephrotic syndrome in blacks. The incidence of focal sclerosis has also increased in Caucasians in the United States. The not otherwise specified classic pattern of focal sclerosis has the worst prognosis. Focal sclerosis is the most frequent form of idiopathic nephrotic syndrome to lead to end-stage renal disease, which is not true. You don't usually get knots on board exams, by the way, but I can give you more data if I put knots in here. Okay, so let's get to our multiple choices. Whoa, this one is just rolling along here. We did it. That was fast. Okay, so, and the 69%, the majority is always right on these. Okay, so not otherwise specified. The classic is not the worst pattern that, as you'll see, we'll go through that in a second here. The incidence of focal sclerosis has increased in whites and in blacks, and it is the most common form of idiopathic nephrotic syndrome to progress to renal failure. So let's look at the data here. Oops. Okay, this is taken from UNC data, University of North Carolina, Charlie Jeanette's pathology group here. And you're looking at a period where somewhere they had about 20,000 biopsies in this period. And if you look at the number one disease down here, focal sclerosis, here it is. It was the number one disease here, stays, comes down a little bit, still the number one disease here. So in terms of this is a very common disease. This is taken from Kaiser Permanente, looking at 2,500 biopsied patients. What's the number one disease? Now, this is Southern California, Kaiser Permanente. The number one disease here is focal segmental sclerosis. And you can see it's running away with this versus membranous minimal change and IgA. Now remember, that is Southern California. That is a very diverse population. It's not like, you can say University of North Carolina, they're seeing a lot of African Americans. In Southern California, they're seeing a lot of whites, a lot of African Americans, and a lot of people of Asian descent. And in fact, if we look among those 2,500 biopsied patients, here's whites, the number one disease was focal sclerosis. African Americans, the number one was focal sclerosis by a lot. Here's Hispanic, and here's Asian, every one of them. So again, there is clearly an increase in focal sclerosis over time, and there's a lot of it. And if you look over time in terms of what progresses to renal failure, so here's the whole US population in terms of focal sclerosis progressing to renal failure, but especially in African Americans. It certainly is the leading cause of progression to end-stage renal disease in African Americans. Now, prognostic variants, there are two. Even though when you look at the classification, it's called the Columbia classification, but I only used two parts of our own classification. One is tip lesion. If you see a defect here at the pole that goes into the tubule, the tubular pole, it's right at the tip it's called, if that's the sclerosing one, that has a very good prognosis. If you see collapsing of the glomeruli, that has a bad prognosis. Collapse is bad, tip is good. So what's the data? This is taken from the Columbia series, but the University of North Carolina series shows exactly the same thing. Here is remission, low with the collapsing, very high with the tip. Here's end-stage renal disease, very high with the collapsing, very low with the tip. This is classic, not otherwise specified, is right in the middle. That's all focal sclerosis. Comes out about the same as the classic one because there's the most of them. So again, things to remember for focal sclerosis. Okay, A 16-year-old African-American male has biopsy-proven classic focal sclerosis and has failed to have his 9 grams of proteinuria remit with prednisone, TAC, or mycophenolate. His chances of achieving a remission with IV cyclophosphamide, rituximab, or ACTH are approximately 70%, 60%, 45%, 20 to 30%. Quick answers. Okay. Oh, yes. Okay. So we got a big bunch right here in terms of this. So it's very low. The bottom line is if you've failed 3 therapies, it is low. Now, I'll show you some data in terms of that in a few minutes, that in terms of with resistant focal sclerosis. But nevertheless, if this person has already failed 2 or 3 drugs, he's down in the resistant group already. Okay, so resistant focal sclerosis, or who else would you use? You might treat steroid failures, or you might treat people who you don't want to give steroids to. Diabetics, somebody who's very obese, you might want to use one of the others. Clearly, cyclosporin and TAC are the 2 that would be used the most, but some people use mycophenolate. The question is these other things, the experimental ones. So this is data that on 82 patients. Now, the abstract we put out in 2017 had 58 patients. These are 82 adults with minimal change or focal sclerosis who were treated with rituximab. They included 43 minimal change, 32 focal sclerosis, 7 podocytopathies, such as an IgA patient with minimal change, such as a C1q nephropathy, etc. 41 were frequent relapsers or steroid dependent. 7 were infrequent relapsers, 9 were steroid resistant, 25 were multi-drug resistant, and the follow-up here is about 2 years. 65% had a complete or partial remission. So it's pretty clear rituximab works in a lot of these patients. 42% of those patients were able to stop everything else. Some of them had to stay on a low dose of steroids, etc., or a little bit of a calcineurin inhibitor. Of the 25 multi-drug resistant, 11 achieved a complete or partial remission, and that was the biggest group that progressed to renal failure. So again, this is data that it's going to be a little more than that when we present it. Well, it's submitted to the ASN. I don't know if we're presenting it or not, the follow-up and the larger number, but we're working on the paper already. But nevertheless, if you have somebody who's failed a bunch of times, if they're frequent relapsing, and you're looking for what drug to use next, you could use TAC or cyclosporin, but they're likely to relapse on that as well. The rituximab is working very well right now. ACTH, limited data. This is John Hogan when he was a fellow at Columbia. He runs the Glomerular Center at Penn now, that put together a group of 24 patients here that you're looking here at people who are multi-drug resistant, getting ACTH for focal sclerosis, 2 complete remissions, 5 partial. So that's 30% of them remitted out of the group in terms of with ACTH. Now, you can say that's good or bad. It just depends on how you look at it. I don't think it's as good as the rituximab, but this wasn't a controlled comparison by any means. This was just a pilot study seeing would we be able to get those people into remission. And of course, then we started using rituximab for a lot of them. Okay, question 9. A 64-year-old white male develops the nephrotic syndrome with 12 grams of proteinuria and a serum albumin of 2.8. His biopsy shows membranous nephropathy with anti-PLA2R staining. He's read online about clotting and asks you about therapy. Which is true about coagulation or anticoagulation in membranous nephropathy? Anticoagulation will not be beneficial unless the serum albumin is lower than 2.2. Data supports oral NOACs over warfarin to prevent thrombosis. Anticoagulation has not proven beneficial in membranous who are PLA2R positive. Anticoagulation should be based on an individual risk-benefit strategy. This question was really to see if you're still awake. Okay, that only took 4 seconds. We're up to 300 responses already. Okay, let's get to the, now this should be 100%. No, it's only 86%. So anticoagulation should be individualized. I meant to mention it, that I'm trying to think, it was Larry who talked about having an albumin less than 2.8 in that study. That is true, that's what that paper said, that if your albumin with membranous was less, your serum albumin was less than 2.8, your clotting tendency went up. But if your albumin, they had it broken in different groups, was 2.6, you actually did better than if your albumin was 2.8. And then at 2.4 and 2.2, everything fit except the 2.6. The lower the albumin, the worse you do in the 2 range. When you're down in the low 2s for an albumin, you're very high risk in membranous to clot. If you're 2.8, you're really not that high. I'd probably watch out for long trips and things like that. But again, the lower you go, the worse you are. And the therapy should be individualized. There just isn't enough data in terms of this. You can use that little diagram that Dan Catran and Ron Falk put together, trying to figure out, who benefits and who doesn't. But, usually you can recognize the fact if somebody comes in with his motorcycle helmet under his arm here, he's a bad risk for anticoagulation. Okay, we don't want to do this. Okay, 70% of patients with primary membranous nephropathy have biopsies that are PLA2R positive. We routinely, I don't know if your centers do it, but we routinely stain all membranous biopsies. Unless we write on the slip that it's a lupus patient, they will stain every membranous patient for PLA2R at Columbia, that out of those 5,000, 6,000 biopsies. Okay, if you have somebody who is PLA2R negative, which features on biopsy suggest a secondary form of the disease rather than primary? Okay, so I sort of told you this for lupus, but which suggests a secondary form? Segmental scarring, mesangial deposits, global glomerulosclerosis, subepithelial deposits without spike formation. So one of these, every time I see it, I look up, say to myself, this is interesting. You can have any of these in idiopathic, but one is much more common in secondary. So let's see what you think. We're almost at 50. We're at 50. Good. Okay. Mesangial deposits is correct. So far, the majority has been right on every single one of these. So mesangial deposits should always make you think of a secondary cause. It could be lupus in a young female. It could be a medication-induced one in an older person, tumor-related. But anytime you see mesangial deposits, even though they say 10% of idiopathic have mesangial, those patients aren't necessarily followed long enough. At least it should raise your eyebrows and you should think about it. Oh, here we go. Here's our mesangial hypercellularity, full house staining for lupus, TRIs for lupus, PLR in idiopathic. Okay, question 11. Which test is usually not part of the evaluation of a patient whose pattern biopsy shows this? Okay, you're looking at this pattern. So this is like, Helmut always does this. What is the pattern that we see here? Now you know the pattern. What are the possibilities? So what would you not look for among these 4 things, looking at a biopsy that shows this? Okay, let's get to the... Now, if you're panicking about boards and everything, first of all, there aren't a lot of biopsies on the boards. And second of all, they're only going to ask clear-cut, obvious things. They're not going to give you even some of the ones that Helmut showed were more subtle. So this is an MPGN type pattern. You can see here as there's proliferation in every capillary loop here, that there's double contours of the basement membrane here. So it's got everything you need. And also you can see there's a little lobularity to it, again, which also, you see it's like broken into lobules. That all goes with the MPGN. So if you looked at this, yes, you do hepatitis serology. Yes, you'd check again for dysproteinemias. It could be light chain deposition disease. It could be heavy chain deposition disease, etc. ANA and complement, absolutely. Membranoproliferative is one of the patterns of lupus. It's considered under diffuse proliferative. You would not check an anti-GBM titer if all the glomeruli looked like this. And the reason you wouldn't is that, wait a minute, I didn't take your vote yet. Okay. Well, the majority voted the right thing, so, okay, here we go. Because this is what anti-GBM is crescenteric. It's almost always a rapidly progressive crescenteric. Here's a typical anti-GBM. Crescent here, big crescent here, capillary loops compressed by a crescent here. If you have no crescents at all on the biopsy, that it's really, really unlikely. I don't even know if it's ever been reported as an anti-GBM. Okay, which therapies have proven effective in producing remissions of the nephrotic syndrome in randomized controlled trials in idiopathic membranous? Okay, so let's see, what do we remember now that Larry Beck taught us? Is it TAC? Are there studies on tacrolimus? Are there studies on ACTH? This is separately, two separate things. Are there studies on both of these? Are there studies on alternate months of steroids and cyclophosphamide? Are there studies on cyclosporin? Are there studies on ACTH? Are there studies on rituximab? Is it all of the above? Okay, so where do we have randomized controlled trials? Almost there, good. Okay. So it's interesting. Okay, so everybody knew there were randomized, like in terms of, if you look at this, that everybody, well, no, not everybody knew that, no. Well, the answer is all of the above. So the majority is right by 2% here. Now, a lot of them, yes, there definitely is data on alternating Ponticelli regimen and cyclosporin, but there's also data on TAC. Larry showed you the data on TAC, not the data on cyclosporin. ACTH has control randomized trial. Who did the trial? Ponticelli did the trial himself. It's positive. And rituximab, of course, there is control data. The Mentor trial is already there. So it's all of the above for this. So this is the Mentor trial, which came out July 4th in the New England Journal here. That actually there are 3 of us from Columbia in here. I got up right next to Fernando, but Pietro Canetta and Jay Radhakrishnan are in here someplace. I want to give them credit. If you look, it's clear that the cyclosporin or the rituximab was not inferior to cyclosporin. At the end of 24 months, it actually was superior. And since Larry didn't show the data here you're looking at, here is therapy here. The blue is cyclosporin. It was a little faster to get into remission than rituximab, but at the end of 1 year, they were identical. But if you looked at relapses, the rituximab didn't relapse at the end of it. I'm a slow learner here. Here you go. The cyclosporin kept relapsing. So essentially, you got the same 70-something% remitting. This study was done in people. They averaged 14 grams of proteinuria for at least 5 months. So this is a group that's very likely to progress. And again, 70% responded with either drug, but you had less relapses over time with rituximab. So a very strong positive study. The editorial that Ramuzzi wrote with it in the New England Journal said that he thinks this should be the first-line drug for membranous nephropathy. And since the biosimilar is already out in the UK and other places, when the biosimilar comes out here and the price comes all the way down, it may very well be. Through? Which year was that? Oh, what year was it published? No. What year was it published? July 4th this year, last month. That was when it was published. Or which year did the drug become biosimilar in the UK? It was within a year. So it's within a year for both of those, and the answer to both of those questions. This is just to show you the Ponticelli child, by the way. So here's methylprednisolone and cyclophosphamide here versus ACTH. 32 patients here. So this group got his regimen. They started with 4 to 10 grams of proteinuria. With ACTH, these are complete and partial remissions. Group B got only the ACTH. They started with 4 to 13 grams of proteinuria. These are complete and partial. They came out the same. Actually, the ACTH looked a little better. Okay, for which glomerular disease has rituximab been approved for use by the FDA? Diffuse proliferative lupus, ANCA-positive vasculitis, IgA nephropathy, steroid-resistant minimal change, and focal sclerosis. Now, this will depend on whether you're taking care of patients who need it, because you know if it's not FDA approved, you've been fighting with the insurance companies. So think back. Now, which guy did you have to fight with for this? Okay, so the majority is correct. ANCA-positive vasculitis, based solely on the RAVE trial. One study, but they just said that, again, this is a life-threatening disease. It is equivalent or superior to cyclophosphamide, so it is FDA approved. It's not FDA approved for lupus, even though we use it all the time because all the studies were negative. It's not FDA approved for IgA nephropathy because, again, the one study that's been done, we did that on 50-something patients. It was a negative study. And steroid-resistant minimal change in focal sclerosis, again, so far we've only put out that abstract. There are studies in kids, but there's not been enough data to go to the FDA. But again, the biosimilar will come out before that's even relevant. Okay, we don't have to go through the RAVE data because you went that. This is the IgA data. We went through that already too. Okay, which therapy has been shown to slow the progression of Alport syndrome? A 6-month course of steroids, eculizumab, ACE inhibitors, no therapy has reduced the progression. For genetic diseases, certainly for glomerular, Alport's is right up there with number 1. And for non-glomerular, I'm sure PKD would be far more important, but Alport's is pretty darn common when you start looking at people who have, either thin basement membrane disease or one allele abnormal. So let's see what we think here. Okay. Oh, wait a minute. The majority, there is no majority here. So it turns out that ACE inhibitors have actually been shown to slow the progression. Now, the way they did this, so I can understand why somebody would say no therapy has reduced it. It's not a randomized control trial. What they did is they used ACE inhibitors and compared them to the SIBs of the people with Alport's, their brothers and sisters. So they compared the course, and on ACE inhibitors tremendously slows the progression of disease. Enough so that the Alport's Foundation, the NKF, everybody is recommending ACE inhibitors and ARBs, even for kids with Alport's. As soon as they have any proteinuria, they're recommending it. So that's what you should do in your patients. I don't know what you do on the boards, but that's what you should do in your patients. Okay, so it's a good thing this is after lunch and not before it. Okay, a 22-year-old white male is seen with a creatinine of 1.8 and 2.4 grams of proteinuria per day. On physical examination, he has the following skin changes. Okay? Which would not be a typical finding in this patient? This is a good board question. So remember what that guy looked like. Okay, which would you not find in this patient? So you have to know what he has wrong with him, and you have to know what are the things that he would have with that. Okay, let's see. We're just hung up. We made it to 50. Good. Okay. So let me go back on this. Okay. So this guy has angiokeratomas diffusum Fabry's disease, essentially. And this is in the bathing suit area. He's got these little maculopapular lesions. This is around the umbilicus. So you know, looking at this is Fabry's disease. Fabry's disease very commonly gets corneal opacities and lens opacities due to the glycosphingolipid piling up in the lens and in the cornea. They get acroparesthesias in their fingers and their toes. They get pain in their fingers and their toes. In fact, they presented a case to me in the CPC at the ASN one time, and the giveaway was the person had pain in his fingertips. This is a biopsy from somebody with Fabry's disease. These are the zebra bodies in the podocytes. Here's a basement membrane, here's another capillary loop, and here are the zebra bodies. This is a biopsy not from Fabry's. This is a biopsy from Alport's. Look at here at the basket weaving, the little laminations here of the basement membrane. So the answer is going to be here 4. This would not be typical. Okay, did I look at the answers here? And the majority is correct. Good. Okay, a 28-year-old white female with a 2-year history of proteinuria and hematuria has this biopsy, which is not likely to be found with this lesion on light and this lesion on electron microscopy. A positive ANA, a C3 nephritic factor, low factor H, low C3 level. Good. A positive ANA is unlikely because this is dense deposit disease. It's got a membranoproliferative pattern, lobular here, increased cells, and here is this dense ribbon of positivity all along the basement membrane. Again, this is not an immune complex. This is complement deposit here, complement components. Oops, let's see what we said here. Yep. Right, the majority was right there. Okay, we're not going to go through this in terms of this. I want to ask you another question. Okay, the other question here. Okay, I'm not even going to give you the stem of the question. Just look at this person. What is the most likely diagnosis? Is it HIV-associated nephropathy, MPGN due to hepatitis C, proliferative GN due to SBE, AA amyloid? I'm going to finish exactly on time, whatever happens here, okay? It's easy, we just stop at whatever question it is. Okay. Okay, majority is right. If you look at this, this is somebody with cryos. That's classic for the rash of cryos. Now, I could have confused you more if you read the case, because this person could have been anybody from the case, but you look at that leg rash, that's what it is. Okay, no, this is too long a question. We don't want to talk. Oh, this is livido reticularis, though, if you haven't seen a good picture of it. It's just somebody in the office. Okay, okay, a 75 is the last question. A 75-year-old white male presents with a 3-week history of low-grade fever, malaise, a petechial skin rash. Biopsy shows a leukocytoclastic vasculitis. His creatinine is 4.8. He has 2.4 grams of proteinuria with red cells and red cell casts. His MPO ANCA is strongly positive. Biopsy shows a crescenteric GN, no IF staining for immunoglobulins or complement. Which statement is true about this patient's disease? Okay. Is PO cyclophosphamide is superior to IV cyclophosphamide? IV rituximab and PO cyclophosphamide are equally effective in inducing remissions. IV rituximab is superior to IV cyclophosphamide in inducing a remission. If effectively treated, he will have a low morbidity and mortality. Now, fortunately for John Niles, he left before he sees your answer to this question. Now you'll see this will be 25%, 25%, 25%. They're trying to decide whether to invite John back again. It depends on the answer to this question. Okay, so, finally, again, the majority is right. IV rituximab and PO cyclophosphamide are equally effective. That's what the RAVE trial, it was PO cyclophosphamide they used in the RAVE trial. That the others are just not true. There's just not data on them. Though, again, there may be more data coming out. But in general, cyclophosphamide and rituximab are equivalent. So we're going to stop now. There are one or two other questions which are in there, which the answers are in your syllabus here, that as I always like to say, I've already told you more than I know about the subject.